Good evening, ladies and gentlemen, for this new Teoxane Academy Geneva live session, broadcasting tonight live from Geneva and from Paris. As you must have noticed, we had small problems, technical issues on our medical platform. So now you will be able to choose your language into the chat. And now let's move on to our tonight topics. This is going to be infraorbital region, and to talk about it, we have two experts in the field with us. The first one, you must know him since you've been with us from the beginning, and if so, this is the Dr. Patrick Trevidic. He is a plastic, aesthetic and reconstructive surgeon from France. He will be introducing this session with an anatomical overview of this challenging area. And now let's head to Paris to say good evening to Dr. Trevidic.
Good evening to everyone. Hope you will enjoy today.
Thank you very much. We will be back to you soon. We have another expert in the field tonight, and this is the Dr. Francesco Bernardini. He is an oculoplastic surgeon from Italy. And well, then he will be injecting live tonight the infraorbital area using the special Gpoint lift technique. And he will do that live from Geneva here in our Teoxane Academy offices. So let's move to him. Where are you? Good evening.
Good evening, everybody. It's an honor, a privilege to be here with you and putting myself to the task of injecting such a difficult area. Thank you, Teoxane, for making this true.
Thank you very much, Dr. Bernardini. We are looking forward to seeing you injecting live in a few moments. But first, I have an announcement to make to you, and this is going to happen right after this session. There will be another live session, but this one will happen on Instagram and on the Instagram account of Teoxane. This is at Teoxane Pro. So make sure to be with us on Instagram to ask all your questions, the questions that might not have been answered tonight. So we will take some more time to answer all your questions, remaining questions, new questions, everything. And our specialist to answer these questions will be Dr. Bernardini. So now let's go back to Paris, and it's up to you, Dr. Trevidic, for the first part of this session.
Thank you very much. And my talk tonight will be on the periorbital area, and a little bit to refresh, your knowledge. I'm sure you know everything on this area, but we will follow the Teoxane approach that you know now very well if you follow us from the beginning. We use Teoxane approach because this is the path you use in your office with your patient. It means when a patient arrives to your office, you do the patient assessment. If you want to correct something to your patient, you need to also understand the aging process. And last but not least, if you want to be safe, you will need to have a good knowledge of your anatomy. Then we move to the technique, T. And we know that there is not one way to inject. And tonight, it's a pleasure for me to join, Francesco Bernardini and to be in live with him on a new injection technique that you will discover tonight. Last but not least, after choosing the technique, you will have to choose the product, the best product for the best technique to get the best outcome. So don't forget the fourth dimension, even if in the infraorbital holo, there is not a lot of movement. So let's start. Where is the anatomical danger when you are looking to the tear trough anatomy? When you are looking to this area, we see that there is a vessel there, and this vessel, you don't want to reach it, because if you reach it, you will have an HA embolism, and this HA embolism will have, a skin necrosis in the forehead, and you don't want to get this kind of patient in your office coming and complain about this adverse event. So you have to understand the 3D anatomy to understand that there is no safe area in the face, but you could be in a safe layer, even if you are in a dangerous area. What does it mean? It means that your anatomy is divided in layers in the face. And you have some areas like the tear trough, for example, or the malar area where it is safe, superficial, and deep. You have another area where it is dangerous deep, the minute line, but safe, superficial. The opposite is the nasolabial fold. And last but not least, areas where the dangers are everywhere, like the glabellar area, the most challenging area to inject. If we are looking to the anatomy, we divide the infraorbital area in two. The question is why we have a tear trough? Because we have an orbicularis oculi muscle that is a flat disc, as you can see here, and this floating disc sticks to the bone just at the area of the tear trough. Look at this video. I lift this floating disc above the soothe, and when I'm going to the inner part of the eyelid, this orbicularis oculi sticks to the bone. So you see here very well that when the soothe finishes, the tear trough starts, and there is a strong adhesion of the tear trough. Why we have a palpable malar groove? So the other part of the infraorbital holo that you can see here. It's not because of a muscle attachment or origin on the bone. It's just because your infraorbital fat compartment decreases with the aging process from the top to the lower part of this area, creating a skeletization that we call the palpable malar groove. So we have a variation in fat. And when we are young, look at this cadaver and look at this young patient, you have a lot of fat that erase, everything. But when you are becoming older, your fat disappear and you have a skeletization of this. You have a variation in bone because the infraorbital margin is going backwards with the time. So if the muscle sticks to this orbital margin, the depression will increase because it will go backwards. And so the muscle will go backwards and create more depression. And you have a variation in skin because in the eyelid, the skin is very thin. This is one of the thinnest of your body. And with the aging process, you have, you lose your laxity. And the last thing is above the depression, you get intraorbital fat that increase with the aging process. It means that this creates a mountain above a valley with the dark circle inside. So this explains what is the aging process in this area with the palpebral malar groove and the tear trough. And here on this dissection, you can see all this area in a complete dissection. You see the orbicularis oculi with the tear trough, the infraorbital fat, and the difference with the palpebral bags. So you can see here that the tear trough is really because you have a strong attachment of this muscle, the orbicularis oculi, to the bone. And if I want to lift that, I need to use my blade to open it and to erase the bony attachment you see on your left side with the dark line on the skull. So here you get exactly the anatomy of the tear trough. And when you will inject deep, you will inject inside this bony origin of this orbicularis oculi muscle. If we are going after to the nasojugal groove that is just under the tear trough, it's very important to understand that the nasojugal groove, it's the dangerous area of this infraorbital hollow, because in the nasojugal groove, you got the path of the angular artery. And the angular artery is the only danger of this area, not for the tear trough injection. The angular artery is the terminal branch of your fascial artery and is superficial to the orbicularis oculi. But it's not going in the tear trough. It's coming in the nasojugal groove and then it's going on the lateral side of the nose. So normally, far away from your injection in your tear trough. It's for that you can do an injection in the tear trough with a cannula or with needle. It's not dangerous to use a needle in the tear trough if you are in contact with the bone. But if you do the same in the nasojugal groove, and moreover superficially, then you have a risk to encounter this fascial artery, this angular artery, and to get something wrong, an adverse event. Look at this dissection. My cannula is in the tear trough above the angular artery, and my needle is just in the angular artery. So look at this drawing. This is to summarize, this anatomy. And if we go to this dissection, you see my cannula in the soup, going in the blue area, and you see where is the angular artery from this area. Let's finish with some words about the ethnicity. Even if we inject Caucasian patient tonight, you have to understand, because we are a worldwide webinar, that there is a difference between Asian and Caucasian skull. And because you have that, the East Asian patients, they have often a big tear trough because they have their infraorbital rim that retrudes a lot with the aging process. This is why there is a lot of demand in, for Asiatic people to get a treatment for this area. In conclusion, you have to understand that the aging process for the tear trough is very specific, and the two areas are totally different. You will see the treatment with Francesco, and also you have no danger in the tear trough, no danger in the palpable malar groove if you are deep, and the danger are far away. So let's go to see if Francesco is ready.
Thank you very much, Dr. Trevidic, for this introduction. And just before we move on, I would like to tell you, if you are watching us and you want to choose your language, you can do it at the bottom of your screen. You can just click on the link and you will be able to choose your language for the translation. So now let's move on to the live injection. As you just said it, Dr. Trevidic, of course you stay with us and you'll be able to comment what you are going to see tonight as well. So let's move to you, Dr. Bernardini.
Hello, Patrick. Thank you very much for your beautiful introduction and presentation. And I want to share with you my beautiful patient and model for tonight, Emily. She's 35 years of age, and she came here because concern of her under eye area. And that is exactly what is correct for us. She delivered a beautiful baby over a year ago, and she noticed a change in under eye. She feels tired and saddened by that, and that she would like to look more fresh and young, and back to her pre-maternal state. So when we look at patients like Emily here, it's very frequent to hear many doctors, also very expert injectors, as focusing only on the tear trough, which is only the medial third of the area. But if you look at her, and I'll ask Emily to just show her face like that, it's evident that is not the major or the only thing here. Actually, if I look at her statically, what I notice first is the lateral third, and then the center, the V deformity. So I will not ever treat directly the tear trough region as such to improve her appearance, because I would only make a bolus here, would not just take care of everything. So here the plan is, and that is what the technique is about, the plan is to treat the entire eyelid cheek junction, improving the appearance of the whole orbital palpebral groove and not just the tear trough. So the other thing I want to point out, how important is the lateral part here higher, is something that is always very often neglected by injectors. So let's move on to the treatment plan. As a surgeon, I'm used to draw on the patient before doing my surgery, do the same thing as an injector, and I prepare for myself every time, each time I draw my intraoral lines from the trago to the ala of the nose, and then from the corner of the eye to the corner of the mouth, then a bisetrix between these two lines that meet, forming a 90-degree angle with a tangent from the corner of the eye. So this is the point that is G-point. Why do we call it that? Because you don't want to miss it, so you need something to think of. And that's the highest part of the malar eminence, is above the malar eminence, is the shortest. That's what makes everything look better. So once we draw that, I like to continue with drawing the defect itself, which is the V deformity. And I just draw the defect. I then palpate the orbital bone with my finger, and I put my upper limit right at the orbital rim. So here comes my superior limit. From this part on is I will not go. So that is the orbital rim. So now I prepare myself for depicting the entry point, which is at the apex of the V deformity, of the inverted V of the smile, right midway on the nasolabial fold. I prepare myself with an algorithm of treatment. This is the first point of injection, the G point. Then I go to the orbital contour padding. Is 3 points lateral. Then there is the center, the apex of the V deformity is 3 vertical, and then we have medial 3 points. So this is, I will tell you the quantity. This is my baseline algorithm for the treatment of the infraorbital region. So I do prepare the same thing on the other side. So just a repetition. I go quicker. I draw the inner lines. I make it a bisetrix there. That's the G point right there. And again, the V deformity right here. I mark the defect right there. So then I palpate with my finger on top of the orbital rim. And this is the patient is being prepared. Finally, I prepare my points of treatment. Lateral, central, on the rim, at the apex and just below, and medial. 3 points right there. So this is my, and I need the entry point. So now I put my sterile gloves on. The patient was already prepped, so I need to quickly re-prep the patient only.
May we zip? Francesco, do you?
Oui, Patrick. Yes, very well.
How do you find this point, this G point? Why will you do something here? Why do you want to achieve?
Here is the point that really, thank you for your question. That's very important. This G point has been called like that. I started to say it, but the G point is because it's a specific point where I want to use a specific G prime and achieve a stretching of the facial ligaments there that stretches the tissue here. So I really achieve a lift instead of filling. So, and the other reason why this point is being called G is because it's been proposed by Gabriella Casabona. So we just call it like that. We like to call it like that. There are many reasons, but that the thing is most injectors tend to over-inject in the center, while the theory behind this, thanks to Gabriella's publication and Cotofana, and I was lucky enough to publish with them, we have demonstrated by injecting lateral to the line of ligaments, you achieve an indirect effect on the nasolabial fold and a lifting effect that is long-lasting. So here is my entry point. Then the cannula is a 20G, 50 millimeter long cannula that glides under the superficial dermis. It's a very simple gliding plane that is virtually painless to the patient. Then when I'm here, I make sure I'm very deep.
So you start superficially and you go deep?
Exactly, Patrick. And then here I want to be as deep as possible, right on the bone. Deep to the...
It's a 22 gauge cannula.
It's a 25, actually.
25, good.
And here I deliver 0.1 cc without moving. It's a macro bolus. It's what is called a macro bolus. I deliver 0.1 cc right there.
With which product?
I'm injecting with RHA4, which I find extremely indicated for this treatment because it has enough G prime, and at the same time has enough stretch to be used in a very dynamic area as the infraorbital area with the orbicularis muscle. So again, I slide superficial, then I pass and go above the orbital rim. So here, I always find the resistance of the orbital retaining ligament. And I want to pass that resistance with my cannula. It's very easy to do so laterally. Here, I will deliver half of a bolus at this lateral point. As you see, this...
So you mean, Francesco, that you will cross the orbital ligament?
Exactly, Patrick. The orbital retaining ligament is basically right with the bottom green line there is where I mark the defect. So when I slide the cannula right here, I feel a resistance. You see the resistance? Then I stabilize the tissue here and I pass that resistance. And now I didn't pass it all the way. Okay, now I pass it and I'm right there. And you see the tip of my cannula is moving right there, but I'm below the orbital rim. So I'm in a space that actually I prepare something for you. Because I knew from an anatomist such as you are, I want to show if it is possible to play on a split screen the anatomic point at the G point. Exactly, thank you very much. At this point, if you want to look under the tissues, you want to know where this filler is being placed, you can play the video now. Here you see my RHA4 being injected at the G point. There you are, right at the G point, deep to the lateral sousp, right on top of the bone. With the tip of my scissors there, I'm right now lifting the underlying vessel that is there, that is zygomatical-facial vessel. That vessel is important, it's right here, and many injectors go there straight in on the bone as normal, and it's an important anastomosis between the internal and external carotid circulation through the transverse facial artery, so I just want to point that out. So again, so I did this first 2 points, then I go to the third, again past the orbital retaining ligament, right there, you see where the tip of my cannula is above, then I stop. Then I deliver half of a bolus, so 0.05, right here. So it's almost an algorithm. Then I go to the apex of the V deformity, where I do the same thing, glide superficial. By doing so, I pass above superficial to the infraorbital artery, so totally safe. But then past the orbital retaining ligament, right there, below the orbital rim, because I can feel it with my non-dominant hand, I deliver 0.02 of product on the uppermost point, then 0.05 right at the at the apex, and then 0.1, a macro bolus down below to provide support.
Dr. Bernardini, we have a question coming in from our viewer.
Okay, go on.
This is your technique adapted to any teeth rough? And could you precise if there are bad indications for the treatment of teeth rough with your technique?
Well, as I want to point now, I'll be replying to that question in just a second, but without stopping. I'm at the bottom, at the tip, at the top, actually, of the teardrop. Right there, you see, where I will be delivering my final bolus right there, okay? So this is the first part of the treatment. I have injected half of a syringe right here, and I stop. I clean up all my marks, and I'll be replying to this question in the meantime. So, first of all, I would stop calling it the tear trough. It's more to the entire infraorbital area. Treatment is just for the palpebral, for the eyelid cheek junction. So I do some massaging to better distribute the product across, to feel if anything is palpating across, but I cannot feel actually really anything. It integrates very well as it is deep under the tissue. And then at this point, I'll look at the change that I achieve with just of this half syringe on this side compared to this side. And you see that is already looking much better. There is some more work to do laterally and all across. So, but now we are approaching a very delicate area, and I will use a dedicated product for that. So, you already know, Patrick, which product I'm talking about. I come here from the Gpoint entry, here, laterally, right there. And as you saw, I change cannula. I have a new, I change the syringe. I have a new redensity 2 to enter laterally at the Gpoint.
And you are deep.
I will enter, yes, I will enter and slide the cannula on the periosteum. So the patient now will feel something, but not too much, I hope. I will stop right here, the lateral third of the defect. Okay, so I'm here deep as possible, right on top of the periosteum. And I'll be injecting 0.1 cc from here to here. As I exit, I will deliver as evenly as possible 0.1 cc of product as I come out.
What is the difference of depth you got between your RHA4 and
exactly. This is this is the Gpoint, so it's where I place my my RHA4, and we are injecting above on the orbital rim. There is a space between a virtual space that is above on the rim, so we are talking above, injecting above the orbital retaining ligament on the bone. So the air density 2 in this part here is resting on the higher G prime filler here, and that brings the cheek higher towards the eye. So if you look at the patient already, you in a side view, you should see, at least I do from here, but I hope to be able to share this view with you, that the impact here is to be shorten the eyelid with the cheek. So this is getting closer and closer, and I'm not done yet. And as you see, I focus my treatment. You can rest your, perfect. Yes, Patrick?
And when you do your injection of redensity 2, you do like a line, if I understand well.
Exactly.
Above your previous injection of bolus of RHA4, isn't it?
Exactly. And as you see right now, so go on.
So all your products are above the orbital retaining ligaments with 2 lines. First line RHA4 and just above redensity 2, isn't it?
Yes. And as you see, Patrick, I focus a lot of my attention on the details of this lateral part of the lower lid. This is something that I really look into it more accurately than the medial part itself, because I think that is the crucial part. So then I slide under the orbicularis, and as I see, I pass again the orbital retaining ligament as I go down. I'm in the cheek now, so I enter the eye side and exit cheek side, and I deliver retrogradely microboluses of red density 2 across the defect. And as I do so, I climb up towards the tear trough. This is to deliver in a bridging technique minimal amounts of product across the defect, but not just inside the defect only. I'm lifting up. I'm using these linear pillars, if you want to call them, of product across the defect in order to support the defect. Like
it's almost, Francesco, it's almost like a crisscross technique.
Exactly. There are probably there. Yeah, go on.
It's like a crisscross technique with some lines perpendicular to the other one. The one is RHA4 and the other one is redensity 2.
Exactly. Patrick, you have completely grasped the sense of this. In the first case, I passed the orbital retaining ligament coming from down below and going up. In the second case, I'm passing the orbital retaining ligament and the tear trough ligament the other way. So basically, with the other technique is more like placing supporting boluses in specific points at the G point and at the V deform at the apex of the V deformity. Then there is this multiple points here that are contouring, orbital contour padding, something like that. and then fine linear threads of minimal quantity of products across the entire surface of the eye. And it's probably the time when I do check the patient, because for me, is my algorithm consists in injecting in my practice, actually, it's like I need to prepare the patient to what's going to be the cost of the treatment. So it's usually 2 syringes for a treatment as such. The first...
Which amount of redensity to...
We have half of a syringe left in the syringe. So we have used half of a syringe for the first part, and then we have used the second half of redensity 2. So if you could zoom out a bit, I ask the camera right there. You can stop right there. Please give me back some more zoom, just because I want to point out some differences. More zoom. Zoom in if you can. Just a full face. Oh, perfect. Right there. If you look at her face, you can tell how many differences are noticeable there. So she has a shortened eyelid cheek distance right there. The cheek seems lifted, and she has not been treated in the nasolabial fold. She looks really treated. So to me, this is a very good example of how to treat indirectly the nasolabial fold. This is why I was explaining why it's so important to use those line of ligaments stretching, lifting instead of filling, not too much into the defect itself. Usually injectors would place 0.5 cc syringe right into there, hoping to stretch a ligament that is attached deep to the bone. So this is a little more difficult. So by focusing to something else, like to addressing the entire thing, you achieve a better result, a more natural result. You inject less product in the tear trough, so you would expect less complication, and you would be able to indirectly address the entire midface. So this is usually a point in my office where I place the mirror in front of the patient, and I ask to look at herself and see, usually in this case I need to pay her to be happy, but usually they are naturally happy.
But Dr. Bernardini, I have 2 questions for you.
Yes.
Let me start with Dr. Trevidic. What about some patients who have malar pads? Sometimes injecting them, the soothe, even deeply, will increase their problem. What are your tips for that, please?
Exactly. That is a perfectly placed question. And in the meantime, I want to show something else that we have prepared for you. So if you don't pass the orbital... Okay, Patrick, thank you very much. Can you please play the anatomy video again? But exactly. Now we have the cadaver demonstration of where my treatment went. This is using the technique. The blue filler is RHA4. The pink filler is the redensity 2 injected as such. The green filler is, again, redensity 2 injected straight in with a needle. So that is an important analysis to make. The blue filler is placed between the orbicularis retaining ligament and the bone. There is actually a real space where you can put your filler. So you pass the ligament, you have a virtual space between the orbital retaining ligament, which inserts onto the anterior surface of the maxilla, and you have a space with the arcus marginalis, which is the orbital septum inserting inside the orbit. So that's where you want to go. Because if you don't go there and you stay in the cheek, then you make the cheek more fuller, but you're not treating the defect. So you eventually make the defect worse. The pink filler there is redensity 2. Where is it placed? It is placed in the orbicularis muscle because there is no ligament between the orbicularis muscle and the bone itself. The orbicularis dives in directly on the bone. And in fact, the green filler is always redensity 2 injected with a needle straight onto the bone. They both lie in the same plane because there is no such a pre-periostal plane there. It's only a deep orbicularis. So we need to come to understand then there is orbicularis fixed, attached to the bone, and on top of that there is a sliding orbicularis that moves about. So we really need to inject deep to the sliding orbicularis, but we cannot be on the bone. We are somewhere deep on the fixed orbicularis. So in the meantime that I can take your question as many as you want, I'm pleased to, I can treat the other side and see if I can achieve the same result.
Let me go back to Dr. Trevidic. We have another question for you, and this is: how do you deal with lymphatic edema? What are your advices to avoid malar edema?
That is a beautiful question. That's avoiding lymphatic edema is this: injecting less product as such into the delicate area as the tear trough. And by not engorging the mid part of the infraorbital region with deeply placed, very thick fillers right there, you just slide with very dedicated fillers in the good position. You inject less product there, and you now you're again going back there.
Why, yeah. Francesco, you don't use your entrance point, your Gpoint, to put your RHA4? Is there any behind? Is there any something you want to achieve by the crisscross, or it is just a question of entrance point?
I think, Patrick, by entering down below in the first part, I give height to the cheek. I bring back the fat pads that descended, they atrophied during the time, and they are exposing more of that bone. So I like to put like an edge to the descended fat pads there.
Could you do the same? Could you do the same with a bolus technique through the skin? With
I wouldn't be so sure, but probably you know, like there are so many ways of achieving the same concept. But the concept here is, you know, like I'm passing the orbital retaining ligament, I'm under the orbital rim because I don't want to be above. I inject very minor quantity there. Then as I go backwards outside, I keep injecting by total right there, macrobolus down there. Then I go back up, slide.
So your last bolus of RHA4, to be precise, in the inner side, where you are going right now.
Yes.
It will be for you the nasojugal groove or the lower part of your tear trough?
It's going to be between here and here. There's going to be 3 points. 1, 2, 3. The quantities change. I inject not a 0.05. I inject 0.02 or 0.03 at most. Now I'm in the between the two. And again, 0.02.
So here you are in the tear trough.
Yes, this is from this is the center, the V deformity. From here, these 3 points basically are, this is a confluence between the two defects, the tear trough and the nasojugal, but the other two are definitely in the tear trough. So, but here inject, so if we count the cc of products injecting straight in the tear trough, so you see here, I'm all the way up and I deliver 0.02.
Dr. Bernardini, we would like to have Dr. Trevidic's point of view on the last question that was about the lymphatic edema. Dr. Trevidic, can you give us your point of view?
Yes, if we are looking to the malar mons, so it means the swelling in the malar area, in my point of view, if you are not an advanced injectors, in my point of view, you need not to inject hyaluronic acid in this area, because if you are deep like you saw with Francesco, there is no issue, but your product will go a little bit superficially, you will have the risk to attract some water in an area where you have a swelling. So you will do the opposite of what you want to do. So you need to be advanced. If you are not advanced, please, if you have a malarmonde, a swelling in this area, don't do injection in this area, because you can encounter an increasing of your swelling.
Very much for sharing your views. Dr. Bernardini, another question for you this time, and this is, you're using a cannula. Can we do the Gpoint technique directly with a needle? Is it safe?
Absolutely. You can definitely do that, and it's the Gpoint. It is safe. It's not unsafe. Absolutely, especially when you inject. When you inject the Gpoint, here there's no problem. Well, I pointed out that there is a zygomatic facial artery, but definitely you don't want to. The beauty of this dynamic, resilient hyaluronic acid is that you don't have to be all the way attached to the bone. You can inject a little more superficial. And then when I use a needle, I come from down below, I grasp the tissue like that, I lift it up, so the vessel will stay down. I'm a little higher. I'm not really on the bone, so I'm play safe. The reason why I don't like to use needles on the infraorbital region is just to avoid that pain. Actually, at every needling is painful, and also I want to avoid the risk of bruising the patient, because as you see. Here, I don't expect any bruising at all.
This is really true what you said, Francesco. We use a cannula in this area, not for safety reason. It's mostly to avoid the bruising that each time you can get when you cross the skin with a needle. And
exactly.
We know that this bruising will last a long time in this area, and all the relatives around the patient will ask her, what did you do? And so this is why, like you, I love to use a cannula in this area.
Yeah, this is the only place where I use, only in my practice, 100% of the time I use a cannula. I would never use a needle. But you can, theoretically, you can. But remember, as the Americans say, you bruise them, you lose them. So, yeah. You know, like the patient nowadays are incredibly high expectation. They expect to be able to go out with their friends tonight and look better already. So tomorrow they want to. Yes?
Francesco, here you did something different from the others.
Yes. I'm taking advantage of being distracted by the audience. I'm just playing around with the elongation of the zygomatic arch by projecting it higher, like past the Gpoint. So the Gpoint medially is treating the infraorbital region. With this, it gives it a plus of projection. And as you see, Patrick, here I'm really taking all the time. I don't like to see this. You see this depression here. This step is something that I really like to do before addressing the medial part. So we are far from the tear trough here, so far as possible, but still is the most important thing that I want to do with her and with my patient by focusing on this area. And I think just by doing this, you're already improving quite a lot. So from now on, I again enter, I stay deep, enter with a cannula.
So you were doing that with red density too?
Yes, you can do with red density too. It's soft, it's smooth. You don't have, when I have red density 2, you can place it superficial in this area. And here I'm doing the bridging technique, sorry.
So what is interesting in the talk of Francesco is with the aging process, your eyelid, your lower eyelid, look to lengthen. And if you want to rejuvenate your lower eyelid, you will have to shorten the aspect of your lower eyelid. And the only way, and I really agree 100% with Francesco, you need at this time to do injection very high where you have the orbital rim if you want to do something in the eyelid. If your injections are a little bit too low, you will not create, you will not shorten your eyelids. This is the secret of the rejuvenation of this area.
Thank you, Patrick.
Bernardini, another
Yes.
question for you. You were talking before about cannula, but let's talk about the difference between male and female patients. The question is how your technique will be different in male patients regarding the Gpoint. Any difference between treating male and female?
Well, this is the only time where a Gpoint doesn't really is for for everybody, for male and female alike, because you really need to consider that the eyelid cheek junction is a unisex problem. Male and female have the same problem alike. It's not there is no difference. So I would use the same technique instead of projecting the zygomatic arch high as in a female, like to give her like a cat eye look. I would stay a little lower and project a little more laterally here to give more like masculine look, Viking look, if you will, and that is, and the beauty, just since we have a few minutes left, and the patient really, this is, like I can't stop right here, but I usually finish up the treatment for the Gpoint. Treatment is part of, there's no point of like treating indirectly the nasolabial fold. And it's the same concept. If you look at, I treat the most delicate part like the deep piriform space, and again, it's a bridging technique.
Which product do you use?
Here, I went back to RHA4. And I go across the...
And you are superficial.
Look how superficial I am.
Yeah.
And you don't see any lump or bump. That's the beauty of these products. You can really, this is a very dynamic area, but she has a fold. So you can, but I have injected 0.2 cc from here to here, and the fold is already done. From this entry point, the same entry point, you can direct your cannula superficially down to the bottom part of the nasolabial fold, and also down to the corner of the mouth, right there. Just give support and come back up. And this is, to top it off, is just like looking much better already. And so eventually, I'm not here to inject the nasolabial, but if I had to, now here, I would take the needle that comes with a 30G needle. I don't know if I'm totally out of the topic of the here, and I should stop and take only questions. But since there's a silence that I take as a positive.
So you mean that you will inject your nasolabial fold with the cannula and with the needle too?
Yes. That is the nasolabial fold has been treated for me. So now there is this difficult line here, like perioral line, smile line. And this part is with a cannula is really difficult to get to it. And so that's why I would take a slide onto a needle, enter very superficial here, and retrogradely release a tiny amount of product.
Bernardini, let's just go back quickly to the orbicular ligament.
Okay.
The question is, doesn't the orbicular ligament tear too much with this manipulation, and is it painful?
We could ask the patient how painful this treatment was.
It was painless.
painless. That's what she said. It was painless. Actually, this is my. But of course.
Tu sens un peu.
Wow.
Ça fait pas peur.
Oh, très peu. Elle a dit. She said that it's very little, very little. But there is a trick to this. So let's get back to the technique at hand. If you try and go, since we are here, I go to the refinement. I see a diva minor, so I finish it up. So, and I'll explain. If you try and go deeper here, now you're moving all the ligaments of the face. You get into the deep facial compartments where you know there are vessels, there are muscle insertion, there are strong ligaments there. That is painful as hell. So you wanna, the trick is this, the non-dominant hand. And the trick is almost over. So you do this, lift up, stabilize the tissue, and slide outside. That's so painless. So here you are superficial. You can see the cannula right there. She didn't feel a thing. And then here you can pass the ligament, and she possibly didn't even feel less eventually. I'm over here, and then up. So
well, thank you very much. I just have another question for Dr. Trevidic. Can you compare the water retention of Redensity 2 versus RH1? And which product do you prefer for treating the teeth rough, Redensity 2 or RHA1? Sorry.
This
is for Dr. Trevidic. The question is for Dr. Trevidic.
Thank you.
This is a good question. When you are looking to the differences between these two products, Redensity 2 is a mix of crosslink and non-crosslink products, and RHA1 is a mix of crosslink and non-crosslink products. What is the difference between these two products? It's the average of crosslink and non-crosslink. And the other differences between these two products is the modification degree, because Redensity 2 is an older product and RHA1 is the newest product with a low modification degree and lower than the Redensity 2. So because I did the European study for Redensity 2 and I'm used to use it every day, I use Redensity 2 as soon as I am in the periorbital area. But if I was in a desert island with only RHA1, I will use RHA1 because it's a very good product also for the tear trough. And I think Francesco will agree with that.
100%.
It's almost the same product regarding the hydrophilic property of these two products.
Dr. Trevidic, can you say a few words to avoid the Tyndall effect?
Tyndall effect, it's an effect because you inject a product that will reflect the light through the skin, and you reflect the light because of the physical property of your HA product. This is the first point. And the second point is because you injected this product too superficially, so the light is going through the skin and the reflection of the light will give the Tyndall effect. So if you want to avoid a Tyndall effect, first you need to use not a too much cohesive product and not a biphasic product. And the other point, you need not under a thin skin to put your product just under the skin. You have to be deep to avoid the Tyndall effect. This is why our advice is to inject Redensity 2 that has, this capacity to mix, crosslink and non-crosslink with a deep injection. And so like this, the Tyndall effect is very low with the million of syringes used by our consumers using Redensity 2. The rate is very, very low. It's because we inject small quantity. This is the first rule of this injection. We also inject these products deep, and we inject, as you saw with Francesco, with a slow motion. We don't want to traumatize this area. This is why we have such a low rate of Tyndall effect with redensity 2.
Thank you very much for this explanation, Dr. Trevidic. And we have a last question to you, Dr. Bernardini. Here it is. Do you always use both types of products, Redensity 2 and RHA4? Or do you sometimes only work with one of these Teoxane products? And when RHA4 is not available, can I use Ultra Deep?
Excellent question. If everything depends on the patient's appearance and the degree of the defect that she has. But as a rule of thumb, if it's a yes or no, I do use them both 100% of the time. So if there are cases where the patient has minimal defect and I think I can get by achieving a good result with just one syringe, or we have a very strict budget, then I have to choose one syringe. Then I would choose 100% of the time Redensity 2, because that's the only product authorized. This is the best product to treat the area. It's in my hands. It's nothing that behaves as such. I would use a Redensity 2. But again, I would start laterally, addressing the lateral part first, then centrally, and then medially. In this case, that patient means that she has enough of cheek support that I do not need to use the RHA4. And there are cases where I use an Ultra Dip. Yes, there definitely are. When you have a very thick skin and an important defect, and you want to really lift the tissues up, Ultra Dip is also a very good product. With the difference that I make by using the Ultra Dip compared to RHA4, since RHA4 is the new dynamic fillers that can be injected, as you have seen, more superficially. When I use Ultra Dip, I really want to stay deep as I can, but that is one of the best products as a lifter that I can really heavy duties. That is my my product to go to. So, but ideally RHA4 and Redensity 2. In selected cases, I move down up, if you will, to with the Ultra Dip.
Well, thank you very much, Dr. Bernardini. And this is already the conclusion of this session. So I would like to thank you very much, dear gentlemen, Dr. Trevidic in Paris and Dr. Bernardini here in Geneva. Thank you for being with us tonight and for your explanation and live injections. We would like also to thank you, our viewers. Thank you for being with us tonight. We hope that you've enjoyed this session. And don't forget that in a few moments, you will have another live session with questions answered by Dr. Bernardini. It's going to happen on Instagram. So you have to connect to the Teoxane Pro account, and you will be able to ask a lot more questions with the Dr. Bernardini answering them. Thank you very much for being with us tonight. We would like to wish you a great evening, and of course we will meet again next month. In the meantime, stay safe. Bye-bye.